All right, let's talk about respiration. Um, we have. I gotta click on the thing. There we go. So what I want you to do is just take in a breath, like a yoga class, right? So focus on your breath. If you haven't been to a yoga class, it's mostly about breathing. So take in a breath. What happens to your rib cage while you're breathing in? It gets larger, right? Like increases in size. So what's happening? Put your hand on your stomach. Moves out, right? So the rib cage expands. Now put your hand on your sternum right here, or breastbone. It's this hard bone right here. What's going on with the sternum? That moves out a little bit. You should try this. Do this along, while we're talking about these. You can feel all these different forces moving uh, while you're breathing. And then also, what's going to happen is you're going to forget how to breathe exactly because you're going to forget how to breathe without thinking about it. Now you're like, breathe in, breathe out, and now you're only focusing on how to breathe. But if you also try to focus on the rest of the lecture, your breathing will come back to normal. So this is exactly what's going on. Top picture to the right, which is somewhat behind my head. We've got a couple of things going on. The sternum itself is kind of like this pump handle thing. We're going to see a couple of things in this slideshow. I didn't make these analogies. These are like from the textbook, but I think that maybe the person who made these analogies was born in like the 1870s because a lot of these don't really work anymore. Bucket handle, yeah. Like technology has not surpassed a bucket. It maybe never will. But a pump handle like this, I have not used one. I've seen one at museums. And usually they don't work. Like at campsites, and then you play with them and like they're not connected. They just haven't taken them out yet. So it'd be cool if they worked, but they don't. Anyway, I'm willing to bet if you're not into like camping, you may have never interacted with one of these. So anyway, imagine this thing you've never seen, which is like a pump handle and moves like this. That's what's going on with the sternum. So sternum's connected to the clavicle up here, and it's going to move a little bit outwards, like a pump handle. So it stays connected at the top, and it'll hinge out on that point, the top point here. But it'll move out like this. Now, bucket handle, yeah, again, we've all got buckets. We've all used buckets, I guess. I'm sure everybody's used a bucket, right? So the ribs are a bit like a bucket handle. So you can see that in the picture here to that way of me, they come up, they hinge upwards and outwards. And what all this does is it expands the rib cage. So here's your ribs. They're down. Camera's not, I'm going to have to go further up. Okay, so your ribs are down, and then they'll come out like this. Boop, as you breathe. Boop, like that. So you've got sternum comes out, you've got ribs come out like that. What's going on here is all these forces together increase the size of your thoracic cavity. That's the cavity inside the rib cage. And then we've got one more thing that's happening, which is not one that you can feel. Well, sort of. So I had you put your hand on your stomach. So you've got the diaphragm muscle right here. This is the thoracic cavity. Well, actually, here's the diaphragm muscle. That's a better place to look at it. Here's the diaphragm muscle. And it's below all of your rib cage, other stuff that we've been talking about right here is your arms, your head, and the diaphragm is right here. The diaphragm forms the bottom of the thoracic cavity, so The lungs are inside the thoracic cavity. The heart's inside the thoracic cavity. The rib cage surrounds the thoracic cavity, and the diaphragm forms the inferior edge of the thoracic cavity. What happens when you breathe in is your diaphragm here is going to move down where it says maximally flattened. So it's going to go into a very flat shape right here. At rest, it's usually domed like this, up. And then as you breathe in, these arrows right here show that it's going to come down and flatten out. So it's usually domed, and then it flattens out. And what that does is also expands the thoracic cavity. And everything that's underneath the diaphragm, all the junk in your stomach that we don't have to talk about in this class, like intestines and spleens and stuff like that, get pushed down and out. So when you breathe in, the stuff in your stomach kind of moves out a little bit. This is why it's really hard to, like if you're not in perfect shape and you go to the pool and you're like, I'm going to like kind of suck in my stomach a little bit. It gets hard to breathe because you're like opposing the natural force of breathing in by holding your stomach in place. Then you have to just start breathing with only your rib cage. And it's not as easy to do that because the diaphragm is one of the major muscles of breathing. Okay, I can't move forward. There we go. We've also got some passive forces as well. So everything that we've been talking about are active forces. Muscles are moving the thoracic cavity, the bones of the thoracic cavity. The diaphragm is one of those muscles. We'll talk about a whole bunch more muscles that move the bones of the thoracic cavity. But there's passive forces as well. So the ribcage muscles, the diaphragm muscle, the abdominal wall muscle, all of these are functioning to enlarge the thoracic cavity. And then when you breathe out, unless you're forcefully breathing out, so let's do another one of these focus on your breathing things. Let's take in a breath and then just let it out. You don't have to force it out. Don't blow the breath out. Just take it in and then let it go. What's going on here is you're not doing anything. Your muscles aren't doing anything when you're breathing out. What's happening is your muscles have contracted to enlarge the rib cage. Air gets pulled in. And then when you breathe out, you're letting go of those muscles. And everything's returning to the shape that it was before. So you've got cartilage, ligaments, lung tissue, the surface tension of the alveoli, and gravity are all pulling back together. So the cartilage, the skin, the lung tissue, they're all expanded, and they want to come back to the shape that they were. Think about like a rubber band. You pull on it, you exert muscular force to pull on the rubber band, and then if you let it go, it comes back to the size that it was. That's what's going on in your breathing apparatus as well. And then gravity a bit, right? If your rib cage is out like this, gravity is going to want to pull it back down. If your sternum is out like this, gravity is going to want to pull it back down. So you've got a little bit of gravity pulling back down on you too. That doesn't mean that you can't breathe in no gravity, and it doesn't mean that you can't breathe when you're hanging upside down. You can, because the recoil forces are a lot larger than any of the forces of gravity, but there is some assistance from gravity. And we can forcefully exhale too. And then that's going to bring in more active forces. These would be the abdominal wall muscles that I've got there. So that's for breathing out. So if you now breathe out a lot, like below where you want to be, you can feel your abs and obliques down in your stomach pulling like really tight. One of the reasons why if you go to like a comedy show or something like this and afterwards you feel like you've been doing a lot of sit-ups is because you are using the muscles of your abdominal wall, so your abs and your obliques, to make the ha 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 sound. Like it's just like little like grabbing of those abdominal wall muscles to force the air out of you in a laugh. And when you think about it that way, laugh is real weird. It's one of the strangest things that humans do. Anyway, that's forceful to push the air out with your abs. And then if you let go, some air will come back into your lungs. These again are passive forces. You're not necessarily using the muscles of respiration to enlarge your thoracic cavity. You're letting off of the contraction of the abdominal wall muscles, and so everything goes back to where it was. So it can work both ways. That means that our lungs like to be in a state of equilibrium right here. And you can push down on the spring and it'll pop back up. You can pull the spring and it'll come back down. It can always be compressed and pulled, but it always wants to go back to where it was before, to this equilibrium point, which has a little bit of air in it, not a ton, but some. You can breathe in more. You can breathe out below what's there at the equilibrium point. Ta-da. So this is your breath. This is a graph of your breath. So if you breathe again, don't take in a huge breath. Just do normal breathing. That normal breathing that you just did, that's called the tidal volume. Tidal volume is what you do when you're sitting around listening to a lecture, when you're reading, when you're watching TV, all this stuff. When you're not talking or working or anything like that, the breathing that you get when you're just at rest is tidal volume. I just got hiccups for some reason. Probably because I've been doing a bunch of like weird breath stuff. Anyway, like holding my breath. Anyway, so tidal volume is where you are when you're not exerting any forces on you're not taking in or pushing out any air. It's where your usual inhalation exhalation lies. Now here's the thing about tidal volume. When you're doing tidal breathing, you have to use the muscles of inspiration to bring air in, mostly the diaphragm, and then to exhale. This is when we rely on just the passive forces. The passive forces will push the air back out, and you come back to resting level. You can see resting level is right here at the bottom of tidal volume. So tidal volume, tidal breathing starts at resting level. It rises a little bit above resting level and then returns to resting level. So muscles of inspiration are used here, and then nothing is used here. It just goes back to its passive forces. And then a little bit of muscular contraction here, active forces, and then passive forces. Okay, so now things are going to change a little bit. Okay, so inhale your normal tidal volume and then keep going all the way as much as you can. That's your inspiratory reserve volume, all the way up. I'm moving ahead accidentally. There we go. So, inspiratory reserve volume is above your tidal volume. So, inspiratory reserve volume is measured from the top of an inhalation to the rest of the way that you can breathe in. So, top of a tidal inhale to as much as you can go. So tidal, I can't really get back to tidal. Here we go, tidal. There we go. Right there. And then all that above is inspiratory reserve volume. We can do that with expiratory reserve volume too. So go back to tidal breathing. Get to the end of a tidal breathing. So exhale from your tidal breathing and now push all the rest of the air out of your lungs. Engage your abdominal wall muscles. That's your expiratory reserve volume. It gets hard to do after a while. And it feels like you can keep going but like diminishing returns. That's your expiratory reserve volume. That's what you can actually push out from the bottom of a tidal breathing, so your resting level, to as much as you can actually breathe out. Below that, there is still some air in the lungs. That's called the reserve volume. That's what's in the lungs after you can breathe all of it out. There's still a little bit of air in there. And so this is, if you're being pushed on, let's say during like an arrest or something, or if you get crushed by, like, if you're caving or something starts pushing against you, you can, the idea is that if you can talk, you can breathe. Well, it's not true, because you can push out ERV and RV, your expiratory reserve volume, and your residual volume, your reserve volume, down here, that you usually can't dip into. But if you have pressure pushing on you, you can use it. And so you can call for help or say that you can't breathe. And that doesn't mean that you can. So being able to talk, being able to put your vocal folds together in the place where air is escaping under a force, doesn't mean that you can actually breathe back in. Now let's switch from volumes to capacities. Total lung capacity, this is an easy one. It's just like everything your lungs can do. It's the volume of air in the lungs after a maximum inspiration. So all the complete air that's in the lungs, all the way up to inspiratory reserve volume. It's everything that could possibly be in the lungs. That's your total lung capacity. Great. Easy one. The vital capacity is anything that you are under control of. So vital capacity, as much as you can breathe in, it goes to the very top of an inhale, but then also to the very bottom of as much as you can possibly exhale. Still trying. That's your vital capacity. Total lung capacity includes what you can't control. Vital capacity is only what you can control. The inspiratory I thought I had a color that was going to show up for that. The inspiratory capacity is everything that can be inspired from your resting level. So starting at resting level, everything that can be breathed in, that's inspiratory capacity. You can think about that as tidal volume plus inspiratory reserve volume. That equals inspiratory capacity. And functional residual capacity is how much air is in the lungs below resting level. So you can think about that as your expiratory reserve volume plus your reserve volume. So inspiratory is everything from tidal exhale from your resting level, equilibrium point, up. Functional residual capacity is everything from equilibrium down. We can also look at lung volume usage. So remember I told you that when you're not talking, you're using tidal volume. That's true. This gets a little bit different when you're talking. And the way that you're talking is different. Changes within that as well. So here is the lung volume change. Right here, I'll draw your eyes to this. Can you see my cursor? Not the best. Okay, right here. So this says respiration at the relaxation at the end of a quiet breath. So this is our resting level right here. This is equilibrium. And then resting tidal inspiration. So you go from 40% to 50% of lung capacity. At rest, our equilibrium level is a little bit less than 50% of our lung capacity. So resting level is not halfway. It's a little bit lower than halfway. Which makes sense if you do all of the like focus on your breath stuff that we just did. Sorry. You can feel like you can take in a lot more air from resting level than you can get rid of. So you're closer to you're lower than halfway when you're at resting level, equilibrium level. And then tidal inspiration is about 50% of your lung volume. So tidal volume just oscillates between 40% and 50% of your total lung volume. But if you start speaking, then you're going to take a larger breath. You're going to take in about 60% of what your lungs can hold. And if you think about that, you probably see this, like if you watch my lectures or anybody else's lectures in your online classes, you will see, or just people you talk to in life, when you begin a long sentence, you take in a much larger breath. And that's at conversational level, so it's not like super loud. If you're projecting, so when I'm here in my like home studio with my cool microphone, I don't have to talk nearly as loud as I do when I'm in person classes in a lecture hall. Even though we have a little lavalier microphone to clip on us, I still, end up like projecting to the room. And so then you end up about 80% of your lung capacity. So if you're going to yell or talk very loud, you take in more air. And then vigorous yawning, you get to about 95% of your total volume. Vigorous yawning sounds like, if you're yawning, are you doing anything vigorously? I don't know. That's crazy. And then they've also got expiration during vigorous laughing down here. So like you can really, I guess, get a workout from just yawning and laughing vigorously. Okay, so that's it about the actual usage of your lung volumes. But let's talk about Boyle's law. This is a pretty important concept. You're not going to have to do any sort of, it's a formula, but you don't have to do any calculations with it. Boyle's law is basically just saying that there's an inverse relationship between volume and pressure. That's it. So what I'm going to start with telling you here is the air is always under a certain amount of pressure. There's just barometric pressure, like the air that surrounds us. It's about 15 pounds per square inch. This is like outside. If you walk outside right now, it's about 15 psi at sea level. It gets less as you get higher. Like less psi, there's not as much air pressure as you get higher. So if you live on the tippy top of a mountain, there's probably less atmospheric pressure than there is where I am, but it's not a ton less. It's still pretty close to the same level. And then if a storm is moving in, the barometric pressure usually increases. And the thing about air molecules is they like to be evenly distributed. This is called dispersion or diffusion. And if you have a bunch of molecules all condensed in one place and there's another place where there's not a lot, they want to equalize. So they're all going to end up having about the same pressure within whatever sized container they're in. You can think about that like the lungs. Or this weird glass jar with a plunger on it that's in this picture. The local pressure inside the lungs is going to change with the size of the cavity. So it's either going to decrease way below the 15 pounds per square inch that surrounds us, or it's going to increase way beyond the 15 pounds per square inch that surrounds us. There's a reason for this. We'll talk about it in a second. So we're going to use the muscles of inspiration to increase the size of the chamber. What that means is, as the chamber gets larger, it's like this picture on the left, there's much more area. The molecules are going to disperse in there inside all of this room. And as there's fewer molecules, the pressure drops. So you expand the thoracic cavity, the rib cage expands, the sternum expands, the diaphragm contracts, so it gets lower, so you have more room in the thoracic cavity. And that means that the air inside your lungs that's there at resting level, at equilibrium, doesn't have as much pushing on it. There's less. There's a much lower pressure. In fact, you can think of it as a vacuum starts to form inside your lungs. And so what's going to happen is air from outside is going to want to flow into that to try to disperse. There's a vacuum. Now air molecules can come in and join those other air molecules and equalize the pressure between the outside and the inside. And so what that means is you've breathed in air. On the other side, if you, well, I say muscular contraction of lungs. First of all, you don't, I've written this totally like backwards. You don't muscularly contract your lungs. You can let your lungs, you can let the muscles of inspiration go. You can use the muscles of the abdominal wall and some other muscles in the chest cavity that we'll talk about, not of the lungs, but you know what I mean. You can let these off, the muscles of inspiration, let those off. You can use the muscles of expiration to contract the size of the thoracic cavity, and that's going to put the air in your lungs under greater pressure. And so what that's going to do is it becomes like, say, 30 psi inside your lungs or whatever. It's going to want, the air is going to want to come out and meet the air outside that's at 15 psi. So that's going to force you to exhale. Boyle's law is pressure times volume equals a constant value. So if pressure goes up, volume has to go down. It's an inverse relationship between these two. Higher pressure, lower volume. Right? Lowering the volume of the thoracic cavity gets smaller. That means there's more pressure inside of it. Increasing the size of the thoracic cavity, there's less pressure inside. So there's inverse relationship between pressure and velocity. And that's what we're doing when we're breathing. We're just changing pressure and velocity. Volume, not velocity. Sorry. Between pressure and volume. So all breathing is changing the volume of the thoracic cavity. It gets smaller, it gets larger, it gets smaller, it gets larger, and then the air rushes in and out of that gradient that's set up between inside the lungs and outside the lungs. So it feels like, and this is true, I mean, it feels like when you're breathing, you're doing something with your nose or your mouth or something like that. If you just think about, like, how does it feel when you breathe? Like, what do? You do something here that takes in air. It's totally not true. You don't do anything with your face at all, or your mouth. It all happens with the size of the thoracic cavity. So taking in a breath, taking in a large breath, is all about expanding the thoracic cavity. You expand the thoracic cavity, the lungs inside the thoracic cavity expand, and that means the air from out here has to go into the lungs. And then when you breathe out, you decrease the size of the thoracic cavity, and that makes the air shoot back out the mouth into the world. That's breathing. It's all the thoracic cavity changing size. So we've got the vertebral sections. There's 3 different ones that we need to talk about: cervical, thoracic, and lumbar. There's also sacral, the sacral spine, and the coccyx. We don't need to talk about those because they don't really impact breathing. Cervical is at the top. There's 7 of those different vertebral sections. Thoracic comes next. It's here in blue. There's 12 of those. And lumbar is the lowest one that we're going to talk about. That's near your back. And there's 5 of those. In the sacrum, there's also 5 vertebral sections. They're fused together to form just the sacral portion of the spine, which is, again, it's all this fused together portion of the spine. And then there's the coccyx, which there's 4 tiny little pieces of vertebral section that probably at some point would have formed a tail. And in some people still does. Let me know if you have a tail and send pictures. The ones that we need to know: cervical, thoracic, lumbar. There's 7 sections in cervical, 12 in thoracic, 5 in lumbar. Absolutely the best way to remember this, I have to move my head, is thinking about food. Maybe that's not the best way for you to remember these things, but it is for me because I like food. And so 7, 12, and 5 is roughly about food times, right? So 7 a.m., 12 p.m., 5 p.m. Obviously, I know that you're college students. And also, when you're a college professor, your time is weird, just like students. So this all is a little bit early. But remember, soon you'll have a job and you'll have to like go places when it starts. So then you'll have to eat at 7 and you'll probably eat dinner at 5 so that you can go to bed early enough to wake up again early, unless you become a professor. And then you're kind of on college student times because that's when we make our classes. If you have a class that starts at 7, no one goes to it. So you can't have a class at 7. Anyway, 7, 12, 5. Breakfast at 7, lunch at 12, dinner at 5. And then let's think about what you have. Cereal for breakfast. Of course, cereal for breakfast. That's what I did every day from probably kindergarten until I graduated from my bachelor's degree. Cereal for breakfast. Probably mostly during graduate school too, because you don't make money during graduate school. You can't get breakfast burritos very often. Now I sometimes have breakfast burritos, but also sometimes cereal. Count Chocula, great cereal, and also starts with more C's to help you remember cervical. So breakfast at 7, you're having cereal, cervical 7, cereal 7, cervical 7. Cool. Tacos for lunch. Yes, please. If you live in one of these states that has bad Mexican food, I don't know what to tell you, man. Come to Arizona and get some real tacos. You'll thank me. California, you've also got great tacos. New Mexico, you too. Texas, Tex-Mex isn't Mexican food, you guys. Come on. Chicago, oddly enough, great tacos. So if you don't live in California, Arizona, New Mexico, or Chicago, go to one of those places and get a real taco. It's great. And have it for lunch to help you remember that that's thoracic. Tacos at lunch, tacos at 12, thoracic at 12. T12. And then last, lasagna. Nobody has lasagna for breakfast or lunch, so it's got to be for dinner. Dinner lasagna at 5. Lasagna lumbar 5. Okay. Now I'm hungry. You probably are too. Let's talk a little bit more about the spine. Regardless of where we are in the spine, you'll see that there is an inverse size between the vertebral foramen and the vertebral body. The foramen just means whole. You know that from the neuro section where we have the foramen magnum, the large hole. But foramen is just a hole. And so we've got vertebral foramen. This is the vertebral hole right here. And then we've got the vertebral body. Makes sense. That's where the bone is. That's down here. Inverse relationship between the vertebral foramen and the vertebral body. Why is this? Well, because further up, this is the C1 right here. This is your very first cervical vertebrae. This one interfaces directly with the skull. There's basically no vertebral body here at all. It's all vertebral foramen. The whole thing is just a frame for this hole. And that's where the spinal cord goes. The further you go in the body, the further you go down the spine, nerves branch off to go to the body. And as you go from up here, the very first C1, all the way down to like your last lumbar 5, L5, you've lost a lot of nerves, like heading all the way down. All that's left by the time you get to lumbar is leg stuff. And as you start in C1, it's everything. It's the whole body. So you have to have more space for the spinal cord further up than you do down below. What's also cool about this is, I mean, you could just have it get smaller as it goes, but you also have to start adding more bone in there to hold up the rest of the body. At the C1 right here, the only thing that's holding up is the head, the skull, the brain inside, some eyeballs, and like when you're sick, a whole bunch of snot. But, and I guess like, I don't know, jawbreakers if you like walk around eating one of those giant jawbreakers all the time. So that's what's going on up here. It's not holding up a lot. And then as you come down into your taco vertebrae, then you start carrying like the head, the neck, the shoulders, starting to carry the trunk. As you move down towards the lumbar, you're carrying a lot of the body, most of the body. So you need a larger vertebral body to provide the strength and support for the rest of your body. So that's why there's an inverse relationship. Larger hole at top, smaller body at the top. By the time you get down to L5, small foramen, large vertebral body. And then the last thing I want to talk about in here is the C1. We already talked about C1 right here. Nope, that's the same direction. There we go. There it is. Boop, right there, C1. It's also called the atlas. Like, you know, the Greek guy who like holds the world. That's the attachment point between the skull and the spine. And what's really great about the C1 is it protects you from being able to turn your head too far one way or the other. That's what these little facets here are for. Can't rotate too much. If you do, you might internally decapitate yourself. Internal decapitation is also known as atlanto-occipital dislocation. If you watch early seasons of Grey's Anatomy, you know about atlanto-occipital dislocation. Also, I highly recommend early seasons of Grey's Anatomy, but stop at like 5. Do not watch 5 through 20. I haven't watched most of those either, but it just gets ridiculous. It used to be about cool medical cases, and then it's like, you know, there's a bomb in a hospital. Anyway, atlanto-occipital dislocation. This is the atlas. This is the atlanto part, and then occipital is the occipital bone, which is around the occipital lobe. So atlanto-occipital dislocation means the atlas and the occipital bone have been dislocated from one another. That's also called internal decapitation. This is not a great thing. 30% of cases are non-fatal, which is also a nicer way of saying 70% of cases are fatal. And so you have to have those treated right away. What's going on up above to hold up the respiratory system? So we talked about the spine. That's a major anchoring point for everything else that we're going to talk about. From there, we've got the scapula, which is back here. Shoulder blade is what you also have heard the scapula called. Clavicle or collarbone right here. And then sternum and spine. So the scapula comes around back here. It's going to connect near the spine. We move over to the edge of the scapula. The clavicle is going to connect near the edge of the scapula as well. And then it comes forward, connects here near the sternum. And then you've got this nice like hanging structure for the entire respiratory apparatus to hang from. So you've got scapula in the back, the spine in between those, clavicle at the front, and then sternum in the middle here. And everything's hanging from that little formation, like rhomboid formation. In addition to those bones, not muscles, you've also got strong back muscles that are holding everything up. So the pulmonary apparatus is in the front, like the spine is on the back. So it's all in the front. This would be like making everything fall forward. So you have to have strong back muscles back there to hold everything up, like to counteract the weight of the pulmonary apparatus. These muscles, the spinalis, the longissimus, and the iliocostalis, are known collectively as the erector spinae group. And on the exam, all you need to know is the erector spinae group. You don't need to know each one individually. So just like, you know, Some people do know the individual Spice Girls, but it's not important. You only need to know them as Spice Girls. So, same thing with the erector spinae group. These are the muscles that are going to provide support for the rest of the pulmonary apparatus by pulling back on everything and counteracting the weight and movements of the pulmonary apparatus. The diaphragm is our major muscle of breathing. It may not be the only muscle involved in tidal volume. This is, in some people it is, in some people it isn't. There's different amounts of muscular involvement in tidal breathing, but it is the major muscle involved in tidal breathing. It connects to, you can see this right here, the inferior edge of the rib cage. So inferior down here, inferior meaning the bottom edge of the rib cage. The xiphoid process of the sternum. We haven't talked about the anatomy of the sternum yet, but xiphoid process is this bottom pointy part. The L1 through L4 vertebrae, so lasagna 1 through 4. And so that basically means here all along the bottom of the rib cage, and then the lower parts of the spine, and then comes back up. So it's all connected at the bottom of the pulmonary apparatus, and its resting state is domed like a parachute. So it comes up and it takes up a lot of this thoracic cavity space. That means when it innervates and contracts, it's going to move down and open up a lot of thoracic cavity space. Here's a bottom view. We're looking up. We're like sitting in the stomach looking up at the diaphragm right here. And so the red or pink or orange part, whatever color this is all muscle that you're looking at. And then this white part in the middle is tendon. This is called the central tendon. And so essentially what's going on with the central tendon is all the muscular fibers pull against the central tendon. So usually, like in most muscles, let's say the bicep, you've got a muscle that, how do I get my arm in the frame? Okay, this will work better. So you've got a muscle that goes from here to down here. And what you're going to do is you want to bring your hand and forearm up. So what happens is the muscle that does that is here, and it's going to contract, boop, and it's going to bring the forearm up. Okay, easy. You've got muscle in the middle, you've got some tendons at the end for connection points, and then the muscle in the middle contracts. And it pulls in one direction, it brings the arm up. A lot of the muscles in the body work very similarly to that. The diaphragm is a little bit different. The tendon is in the middle, which means all these muscular fibers are pulling against the tendon. What happens when you pull against the tendon? Oh, think about, do you remember parachute day in PE when you were a kid? So what you did was you bring it up, everybody lifts the parachute, and then everybody pulls down at exactly the same time. What happens when you pull down at exactly the same time? It pooches up, right? Like it traps the air, and then you can get inside of it and tell scary stories or whatever. That was my favorite part of PE, was for some reason getting inside of a parachute and telling scary stories. I don't know how that taught us anything about athleticism. Anyway, so you pull down. If everybody pulls down at the same time, the edges come down, and it traps some air inside, and eventually that'll just like deflate. If people don't all pull down at the same time, it doesn't work. So if you don't have people manning the parachute at the other end and you do this, it basically just shakes it like a rug, and all the air inside comes out the other end. That's what's going on with the central tendon. All the muscular fibers have to pull against the central tendon at the same time to pull down on the diaphragm. There's not air resistance inside the stomach, so it doesn't do the thing that the parachute does in PE class. It all just actually falls down quickly. So you end up with a flat diaphragm instead of a domed diaphragm. And that's why the tendon is in the middle. There's only 3 things that pass through the diaphragm. You've got two areas where blood flow goes. So we've got the vena cava and the aorta. Those are passing through. The heart is inside the thoracic cavity. So, of course, blood flow out and coming back to the heart both have to pass through the diaphragm to go to the rest of the body. And the esophagus, because your stomach is below the thoracic cavity, but your mouth is above. So the food tube has to go through the diaphragm. Aside from those three things, nothing else passes through the diaphragm. It's a closed, fairly closed off system. It's not entirely closed off because of blood flow and food.